disclosures, a little bit about our group, which we're relatively new to ICFUST. My name is Seth Hoffman. I'm an infectious diseases specialist and physician scientist, primarily working on global health interventions and outcomes research. I'm a member of the Stephen Luby Lab at Stanford. Our lab is a public health research lab that seeks strategic knowledge to improve human health. Our global public health mission influences the ways we seek out strategies to improve population level health and how we do it. I won't bemoan the topic. Everybody's here because of this, just one slide. We all know that respiratory pathogens pose a grave threat, and there are two aspects that I'd like to discuss. One, the burden of existing respiratory infections is vast. Millions of deaths per year. It's a large part of why we're all here today. In 2021, there were a global estimated 15 billion respiratory infections and 11 million deaths. 11 million is double the current estimated population of Scotland. Number two, the ongoing and increasing threat of pandemics. The factors that allowed COVID-19 to become a pandemic make other pandemics more possible, such as climate change, large-scale agriculture, international air travel. But the risk of a bioengineered pathogen also motivates our group. While naturally arising pandemics are possible and have the potential to be catastrophic, thankfully nature selects for reproductive fitness more often than not. That is not necessarily the case in the context of an engineered pathogen. Far UVC could lead to a revolution in human health, similar to how routine water purification and sanitation led to massive gains in human longevity in the early 20th century. While far UVC may represent an efficacious tool in controlled lab experiments, implementation at scale for population level benefit is currently limited due to a lack of real-world public health data. A rigorously performed randomized controlled trial would produce the kinds of data to support the public health effectiveness of far UVC. So a little bit about the design of the study that we're proposing. And one of the questions we get is why Bangladesh? So Bangladesh is one of the most densely populated countries in the world. The schools in Dhaka, the capital of Bangladesh, convene dozens of students together in small rooms that are not designed for optimal indoor air quality or to minimize respiratory pathogen transmission. Prior work by our group, which has decades of experience in Bangladesh, showed an influenza-like illness incidence rate of 270 per 100,000 person years in Bangladeshi school children, substantially higher than any estimates for the influenza-like illness incidence rate for the US or UK across populations. The high incidence of respiratory infections and high density of these classrooms make them ideal locations for evaluating interventions because they are the likely site of substantial proportion of total transmissions. Our hypothesis is that implementing far UVC and or air filtration in school classrooms will decrease the incidence of PCR-confirmed respiratory viral infections among these school children. We'll do this through a pilot phase to optimize the interventions and the sampling methods and a separate randomized controlled trial. This pilot phase is designed to optimize the social technical implementation of the intervention. The 6 months, really over the course of a year, will involve 1 month of implementation followed by 1 month of assessment, iteratively building on our successes and weaknesses, and will iteratively develop the implementation of our proposal so that it's acceptable to students, teachers, to schools, and so the workflow for surveillance, sample collection, and lab testing is efficient and reproducible. The full trial will take place in 60 government primary schools in Dhaka, Bangladesh, among grades 3, 4, and 5 classrooms, where students are on average 9 to 12 years old. In 5 classrooms per school, with approximately 60 students per classroom, classrooms will receive either air filters, far UVC units, a combination of both, or 2 control rooms, making up our control group. The study will take place over 1 calendar year of surveillance, which includes the 40-week school year and 1 flu season. Briefly on the air filtration intervention, it's simple and affordable. It's just a box fan with an HVAC filter, which is less than $100 to produce. These units have been evaluated by the US CDC in studies, reducing model aerosol exposure by 73%. However, they're loud. 67 decibels. Quieter alternative would be PC fans, but are more expensive, and we'll evaluate both during that pilot phase. For FAR UVC intervention, we'll pilot both using the B1 and B1.5 modules to make a decision for the main trial based on irradiance mapping and acceptability. We will not exceed the ACGIH TLV for eyes, but of note, that would be the 8-hour limit, and these children only are in these classrooms for 4 hours at a time and then go home. There's no shared communal spaces for indoors for school children. Study personnel will visit each school twice per week, identify students who are absent or have evidence of influenza-like illness symptoms, interview them at home, and consent for nasal swab collection. During each twice-weekly classroom visit, study personnel will collect air samples from each classroom for 5 minutes immediately following the end of class using a cyclone-captured aerosol detector to capture aerosols directly into PBS, and they'll be stored at -80 for later testing. And in a subset of schools, we will also perform ambient ozone monitoring at each twice-weekly visit. The primary outcome of this study is PCR-positive influenza or SARS-CoV-2. This combined outcome increases the likelihood of detecting infections and an effect of our interventions. The primary analysis will compare the incidence of the primary outcome in each of the 3 intervention arms versus the incidence in the control arms. It's really 3 separate trials. Classroom-based secondary outcomes will include influenza-like illness, absenteeism, and air quality measures. PM2.5, CO2, VOCs, and ozone as mentioned. Lab-based secondary outcomes will include influenza positivity, SARS-CoV-2 positivity, a multiplex respiratory viral panel positivity, and air sampling results. Briefly on assumptions, our incidence assumptions are based on our group's prior work in Bangladeshi schools, adjusted for the addition of SARS-CoV-2 surveillance. The sample size of 60 schools per single arm is selected to provide greater than 90% power to detect a 30% or greater reduction in disease incidence for each intervention versus control, and greater than 80% statistical power to detect a 25% or greater reduction. It's pretty good numbers. In terms of safety monitoring, just briefly, we'll do weekly symptom monitoring of skin and eyes in students and teachers. We are interested in discussing the possibility of measuring dose on student shoulders or head or the teacher, continuous classroom VOC monitoring of all classrooms and particulate matter, intermittent ozone monitoring of a subset of 15 schools. Just briefly about the project. Fully developed. It's been reviewed and approved by human subjects committees both in the United States and in Bangladesh. And it was actually positively reviewed by the US CDC, and we're waiting on results of a proposal to the US Department of Defense. Just want to thank many groups and individuals who have provided feedback and support on this project over the past greater than 1.5 years, including but not limited to, there's a whole bunch of people in this audience that have also reviewed our proposal. Ushio, FAR UV Technologies, Blueprint Biosecurity, the Oslo Project, and then finally, happy to answer any questions. If you have additional questions, please find me at the conference or my colleague, Dr. Grant Higgard-Resley, who's also here. Thank you very much.